Welcome to the Geros Health Podcast, where we make it easy for you to better serve older adults through our content that informs, community that inspires, and courses that deliver.
Hey, hello everybody. It's Troy Bede here with Geros Health and the Home Health Recharge segment. Today we're shifting gears a little bit and we're talking with John O'Halloran. Some of you may know him, especially us in Greensboro area, know him as the PT, one of the PTs that all the PTs go to. So I'm going to hand it off to John. And John, would you just introduce yourself a little bit?
Well, thank you very much, Troy, for giving me this opportunity to really talk about my career and some of the things that I blend with my seminar teaching as well as my private practice. I have a private practice here in Greensboro. This practice is all orthopedics. It does have a blend of cash-based patients as well as a huge geriatric orthopedic emphasis. I'm housed in a YMCA. Right, so what comes here is the Silver Sneaker program, right? Right across the hall, we have where the Silver Sneakers. Right here is where the bathroom, where they go, the bathroom before class, during class, and after class, right? So they have great exposure to my services. We have an extremely active geriatric population, or what I call geri-active versus geriatrics, right? And, you know, folks here, they love the fact that, hey, I want to stay independent, right? I don't want my kids taking my keys away from me, you know, and I don't want to fall, right? And they know the data, they know all that stuff, and so my approach and my team's approach is that we understand that mindset. And we're all going to get there, and we feel if we continue to do a good job now, good things are going to happen to us later on.
Well, that's great. I think one of the great things about what you have going on here is you're not only, I know you kind of mentioned it a little bit earlier, not only an educator, but you're also, you know, a full-time clinician as well. You're just not out there teaching things, but you're also, you know, putting that into kind of practice and everything you do. And I noticed you do some classes for MedBridge and everything as well. Can you tell us a little bit about what you do for like your teaching and everything, like for MedBridge and your seminars and stuff like that?
Absolutely. You know, when you look at continuing education and getting CEUs, you know, you need to maintain your license. And when I first started doing continuing education courses, and why did I get into it, you know? And I remember a buddy of mine who I used to work in Boston came down, and we're sitting right over there at the Marriott, and he came into town, he stayed there, and we're kicking around some things. And at that time, back in 2000, 2001, 2002, managed care was a topic. And I always enjoyed the fiscal side of outpatient services. So I thought, you know, I think we really need a course. You know, there was a lot of courses out there that told you an awful lot about intervention. You know, they're telling you, okay, you get this rotator cuff repair, this is what you do. But in a managed care environment, you got factors like copays, factors like deductibles. You got factors like utilization control by the insurance companies. And when you have those factors, those research articles that are telling you to do this particular program, they don't include those in the research. They say the patient came to the clinic 3 times a week but whatever. My patients come to the clinic 3 times a month. Okay? So the clinician that can really hone in on the multitude of factors involved of getting an outcome. So I put together this course called The Managed Care Approach with Shoulder Rehabilitation. And I focused on how you use the different factors of an outcome, which are intervention, which is natural history, things take time, patient education, you got to be really good at that now, compliance, right? We always want them to do their home program. And number 5, last but not least, placebo. Placebo, hey, there's research out there that surgeons have operated on the wrong knee, and the patient got better. There's research out there. Recently, 122 patients were in this study, and everybody got a shoulder arthroscopy, right? And some patients got a discoclavicle excision and a subacromial decompression, and the other ones, they just stuck the scope in, and both of them got the same result. So placebo is not a bunch of BS. It is a real part of getting an outcome. So when I look at all the courses that were out there, I went to this search engine and I looked and see, okay, what is everybody teaching? All right, nobody's talking about the absolute practical way that we rehab. This is back, 17 years ago. So got in touch with this continuing education company, which is no longer around, but and we were doing, there was no webinars at that time. And I will say that my personal claim to fame in this business is I was the first guy to do a webinar in orthopedics, and I did it with a company called Home CU Connection out of Plano, Texas. And I did it with this small little camera that they stuck to they sent it to me in the mail. I stuck to it I don't even know if they even have that adapter, but I stuck this little cam on top of my laptop, which was about 30 inches by 34 at the time, right? It was bigger than a suitcase. And I filmed myself talking to this thing for 6 hours at 3 a.m. because I had to get done before the clinic opened, So going back, I've seen it all. So in 2006, first time we ever launched a webinar. So I'm looking around and I'm saying there are three types of presenters out there. There's the research person, the one that's faculty, the one that is not doing a lot of their time in the trenches at this point in their career. They may have had a significant amount of repetitions. They may work in the summer. They may work at the pro bono clinic that the PT school has going on a Tuesday night, supervising students. But they're not in there every single day. I mean, I just saw 23 people, and it's now 12:50. Yesterday I did 28. I did 32 on Monday. That's me personally touching that many folks. I have a great team. I have lots of assistants. So I'll do a lot of manual stuff, a lot of manipulation, and then I'll move to a different room. But I'm in there every single day, and I'm doing all the evals. I'm doing all the outcome measurements. I'm doing all this stuff every single day. And I have a lot of students that come in here, so I have a lot of students give me fresh information. So you have that type of presenter. Then you have the educator. Then you have the clinician, and then you have the blend, And I've done research, but my research is this laboratory right here. This is it. 600 people a month come through here, and I'm always just amazed when you say, that doesn't work what I just saw in JOSPT. That doesn't work because we don't have all those factors. So that's really my love of blending the two. I've always thought, maybe I'll just go put on seminars. And then I'm going, nope, I love coming back to the clinic. And I learn, back in the day, because there were no webinars, you get 50, 60 people for a 6-hour CU class. Now they get 10 that go to those, and then they buy what? Online Learning, MedBridge, and the other companies as well.
That's a great perspective on the differences of each of the presenters. It kind of gets lost. At least we don't think about it that way so much, but I think you're right, especially with some of the research. A certain population of patients come in and they get a certain population that doesn't factor in the cost of that they have to deal with, whether they have a ride to get there, there's a cost, whether they have a $75 copay, whether they have a $0 copay. And so your treatment's going to differ from the one that you can see because they can afford to see you, 15 visits. And then there's the one that you can see maybe 2 or 3 times a month, that you also need to try to help them get better as well.
Exactly.
So going forth now that you have, sounds like you got a basis on what you like to teach on and what you like to work on. Is there anything in the future that you see that you'd like to address that you haven't addressed already in some of your classes?
Yes, and getting into looking at the changing in our population, and I came up with a topic called baby boomers, baby boomer joint replacements for geri-active people. And I was the first one to present a course in 2007 in Las Vegas at the Cross Country Education Summit. And I presented a course, and that was it. Are you boomer ready? Are you boomer ready? Are we ready for these folks that were born between 1946 and 1964, which I'm a proud member of, right? So are we ready? So back in that, when I was in 2007, those first boomers were 60 years old, roughly, right? And they grew up with fitness. And they weren't going to put up with the old-fashioned way that total joint surgeons put up with total hip, for example. So they would say, okay, the posterior approach was the typical way to do a hip replacement at that time. And let's say you're 60 years old, but you like to snow ski and water ski, right? And you had restrictions. And the patient would go in and they go, hey, can I water ski? And the surgeon would go, nope. So the patient would go, see you later. They go for a second opinion. And they would go around and they would find a surgeon that was using a type of hip replacement system, right? The metal on metal, which became prominent around then, that would give you your cake and eat it too. It would give you maximum stability with mobility, because total hip patients would have to sacrifice mobility to remain stable. And the hip's the most stable joint in the body. So it really didn't make sense. But the old system was not designed for baby boomers, active people. It was designed for dress, groom, self-care, go to church, right? But it was not designed for impact loading. So that totally changed rehab. Now, where are we going now? Now we're going anterior approach, minimally invasive surgery, more anatomical placed arthroplasties with our joint replacement populations. Joint replacement is going to be 4 million people are going to have a knee replacement in the next 10 years. Right now, 600,000 knees are being done. It's going to go to 4 million. Hip revision surgery is going to increase in the next 10 years by 137%. So we are going to a place for clinicians. We better get on board with opening up the way that we rehab. We can't think about 3 times a week, 4 weeks. We got to think about 5 visits. We got to think about 5 minutes. And we got to think about what is the most important thing that we need to do that particular time. And then how do we achieve all those factors of an outcome with less utilization of services. So I think moving forward, if you understand the surgery, because a lot of clinicians go in, they see, oh my gosh, I got this patient, I've never seen this procedure before. And you're hesitant. Well, who loses is the patient. If the patient goes to somebody that understands their surgery, the therapist can be more what? Proactive. The therapist can deliver a stronger medicine, right? Rather than, I'm going to go Google all this as soon as you walk out of here. Or I looked it up before you even came in, but when you ask me a question, I really don't know the answer. So we just wasted your $72 copay. Why don't you come in Wednesday? I'll be ready for you. Or I can only do your evaluation today. We have to wait until Wednesday to do your therapy. That kind of stuff. That stuff's 1980, where you didn't have copays, where you had time. Remember, one of the factors of an outcome is natural history, where you have time to make it a pleasant experience, and then the time will take care of the patient's problem. Today, you better know on the front end. And that's really, really where I think we're going. We got to be better trained in understanding the surgical management's implications and the type of person that we're working with. Because little Miss Old Smith over there, yes, absolutely, we're going to be seeing you, but we're going to see a number of 80-year-olds that are physiologically 65, right? Chronologically, they're 80, but they don't want to lose their independence. And our old way of rehab and their fall prevention isn't going to shake it.
I love that. We have so many people in the group that are so interested in the geri-active and thinking differently about how we do, treat as well as prevent some of the injuries that have the baby boomers and and coming generations will be dealing with. And I think that's one of the nice things about a lot of the people in our group that we have is they're thinking differently. Some people are looking at different models of, what, like kind of like what you have here is, a different model of in thinking of how we provide therapy and how we better serve the older adult, as well as some that are looking to open up their own gym/practices. I know you're inside a gym, but you're not, you don't own the gym as well. Do you have any suggestions for people that are like interested in sort of like a model, kind of a geri-active model? Any suggestions for them on how they could like better implement things for their own practice?
I think getting involved. I've always been a big proponent of giving back, and have been well recognized in Greensboro for volunteer work, as well as putting on a tremendous amount of presentations to groups, teams, and organizations, civic clubs, etc. And at the Y we have this active older adult group. And when you get involved with them and you just say, and they're always looking, every single YMCA in the United States has a senior group of some sort, some name, and they're always looking for outside professionals to come in, give a presentation. One of my team members just did something with fall prevention for, you can see it up there, there's a little flyer up there by my kids, on Tai Chi and things like that. So Krista went in and did something with them. So getting yourself out there, you're gonna get a lot more out of it than you think. And we kind of think about, oh geez, we don't have much time, we're all time starved, but give something back, I think is my big message. And also allow the next generation to come in and see you. A lot of us say, we don't take students, even that student that just wants to see what you do. Welcome that. Really show what physical, occupational therapy, athletic training is. As much as you can, give it. We're all in this together. And we're not just, I'm just a skilled care therapist, I'm just a HHPT, I just work inpatient, I just work in we're all the same. We all took the same test. And if we can all just kind of show what we do, keep showing what we do, I think we'll all be better in the long run.
That's excellent advice. Do you have anything else to add that you haven't already mentioned?
I think that when we really, really look at changes in healthcare and we look at utilization of healthcare dollars and we look at the comprehensive approach when it takes to rehabilitation, and I think for anybody that works with a patient, if they have that awareness that there's many factors involved, I think that will really streamline your thought process. You'll deliver a much more specific prescription of your rehabilitation program. You'll find that message will spread, that program was different than maybe their friend, because a lot of these folks out there, they talk. Where did you go to? Who'd you see? Right? And you're going to get a brand. And you're going to be known as this person or that person. So continue to try to be kind of a, self-educator, right? Adult learner, which we talked about earlier, before we started the program. Become a thirst for knowledge as yourself. I mean, if you're listening to a podcast, you're obviously interested, right? But the more you get, the more you learn, whether it's through journal reading, right? Whether it's looking at webinars, listening to podcasts, right? Kicking things around, right? Amongst your colleagues, the more you're going to be able to grow the profession, the more that the public is going to know about you, right? And that's going to spread. And that would be my biggest thing to sum up today.
Well, I really appreciate your time and your perspective and all that you do for the community, as well as all that you do for our group with your classes and everything like that. So again, I appreciate your time, John.
Thank you very much, Troy. I'm glad we got together. Thank you.
Thank you for listening to the Geros Health Podcast. Go to geroshealth.com to get the show notes for this episode and find out how you can join the Geros community for free. You'll get access to our private Facebook group and the weekly Geros Recap, where we share our favorite reads, podcasts, and any interesting conversations in the Geros community that week. Once again, that's GEROS health.com. Thanks for listening.